the umbilical vein to the liver. Now, what is there in the liver? Liver, you have the portal vein. If the placenta through the umbilical vein is shifting the oxygenated blood, it has to bypass the portal vein because everything cannot go to the liver. Otherwise, what will reach the heart? So 50% of the blood is shunted to the liver via the hepatic veins, whereas 50% enters the first shunt. This is the first shunt that we'll talk of. We'll talk of 4 shunts in this entire system. The first shunt being this, which is the ductus venosus. What is the ductus venosus doing? It is shunting 50% of the blood carried by the umbilical vein into the IVC. So 50% goes to the liver, 50% goes to the IVC. From the IVC, the blood directly comes to the right atrium, and from the right atrium through a fossa ovalis, which is basically a defect in between the right atrium and the left atrium. The blood, almost 1/3 of the blood directly flows from the right atrium to the left atrium. 2/3 of the blood will move from right atrium to the right ventricle, and as I said, you can clearly see in this flowchart from the right ventricle, because pulmonary vascular resistance is very, very high in a fetus. As I said, lungs do not take part in oxygenation. Only 5 to 15% of the blood will reach the lungs, whereas 85% of the blood will be shunted at another place. This is the third shunt that I'm talking of. The first shunt was ductus venosus, which was shunting the blood from umbilical vein into the IVC, bypassing the hepatic veins. The second shunt that I talked of was the fossa ovalis, which was leading to a shunt of the blood from the right atrium to the left atrium. The third shunt that I'll talk of is where the right ventricle is draining almost 85% of its blood, shunting it from the lungs, moving it to the systemic circulation, that is the aorta. So that is the ductus arteriosus. From the aorta, the blood is pumped out into the systemic circulation, and it is brought back to the placenta via the umbilical arteries. This takes care of the entire flowchart of the fetal circulation. They've tried explaining in a form of a flowchart. So based on this entire route, if you can just remember this entire route, there are almost 4 to 5 questions that we can solve off straight away. What's the first thing that we can solve off? The first thing is, what is the vessel which is having the maximum saturation of oxygen? You see, from the placenta, it is the umbilical vein which is carrying the oxygenated blood. So naturally, the highest SaO2, or the saturation of oxygen, will be in the umbilical vein, followed by 50% is shunted by ductus venosus, carried to the IVC. So next is IVC, followed by the left ventricle, followed by the right ventricle, followed by the umbilical artery, which receives the minimum amount of saturation. The question that is often asked is, why is the left ventricle saturation more than the right ventricle saturation? So if you actually see, right atrium, as I said, will directly shunt almost 1/3 of its blood straight to LA through the fossa ovalis, which will move to the left ventricle. Right atrium is not just receiving blood from the IVC, but is also receiving deoxygenated blood from the SVC. Because there is a mixing of blood that happens in the right atrium, and finally that blood goes to the right ventricle. So the right ventricle has a mixed content of blood, both oxygenated and deoxygenated. The oxygenated one primarily coming from the umbilical veins, the deoxygenated one coming from the superior vena cava. So because of this mixing, the right ventricle saturation is always lesser than the left ventricle saturation. And finally, umbilical artery, it's a no-brainer. It will always, come and carry the blood back to the placenta, so it will be having the least vascular resistance. This entire order has been asked not just in your NEET PGs or your PG entrance exams, but it has also been asked in your super specialty exams. If you take a look at the past 5-10 years questions. Now, few facts at a glance. As I said, the right atrium directly drains 1/3 of the blood into the left atrium. What allows it? That is something that we need to see, number one. So the eustachian valve and the crista dividens, these are the two structures which will directly divert the blood coming from the IVC into the left atrium via the foramen ovale, correct? Okay, now the RV output is 1.3 times LV output. See, this is the no-brainer. Again, RV receives blood from the right atrium, which is receiving blood not just from the inferior vena cava, but is also receiving the blood from the superior vena cava. Because of this, the right ventricle in toto receives more amount of blood than the left ventricle, which is almost 1.3 times the LV output in a fetus, and hence it handles more blood. The third question is, anytime there is a fetal distress in utero, it always leads to bradycardia. That is exactly the basis of a certain test, which is called a non-stress test. All the gynecologists who are in this platform, if there's anyone, they'll always say this, that, if there is a bradycardia, persistent bradycardia of a mother, of the fetus during in utero monitoring, it always is an ominous sign. Why is it? We know by basic physiology, cardiac output is heart rate into stroke volume, correct? Now, in adults, whenever there is a whenever there is a reduction in stroke volume, there is a concomitant increase in the heart rate. However, a fetal heart is comparatively having a low compliance, which means at any point of time when the stroke volume falls, the heart rate cannot increase to compensate the fall in stroke volume, which is why, due to this low compliance, any kind of fetal distress will always lead to bradycardia, and it will also lead to a fall of cardiac output. Okay, good. Basic questions, again, anatomy questions, very, very simple, straight to the fact, but we start getting confused at times during exams. What is the basic closure of the shunts? Now, why do the shunts close? Once the baby is born, you quickly look to this flowchart. Once the baby is born, we know that the placenta is cut. The moment the placenta is cut, this entire chain of events, which had started with the umbilical vein, will suddenly now start getting stopped. This closure of, the ligation of the placenta and the removal of the placenta completely shuts down the placental circulation, which clearly means all the four shunts that we talked of, the ductus venosus, the foramen ovale, the ductus arteriosus, all of these will now have to close with time. Okay, so what is the reason for the closure of the shunts? The only most important reason is the increase in PaO2 right after birth and the concomitant decrease in the pulmonary vascular resistance, which happens post-birth. Because as I told you, once a baby is born, once the fetus is born, the lungs now become the primary seat of circulation. And because of this, what we usually encounter is the pulmonary vascular resistance, which was very high in utero, starts to fall. This leads to a complete reversal of this entire procedure happening, leading to the closure of the shunts. What are the order in which the shunts close? Well, I remember it by a very famous mnemonic, which is VOA. But so what I mean by V is ductus venosus. What I mean by an O is a foramen ovale, and A is nothing but the ductus arteriosus. That is the order in which there's a functional closure, and later there is an anatomical closure. So that is actually the order that I want to talk of. The remnants are often asked as anatomy questions for the people who are right now doing their internship or in your MBBS final years. Ductus venosus leaves a remnant as the ligamentum venosum. The foramen ovale leaves the remnant as the fossa ovalis, and the ductus arteriosus is famously leaving the remnant as a ligamentum arteriosum. So when I talk of ductus arteriosus closures, there are a few things that I want to right away deal with it, because when I go to a disease where the ductus remains open, even in postnatal life, that is called a PDA or a famous patent ductus arteriosus, that is exactly where these concepts will come into place, which is why I have put this content right here. So the ductus arteriosus physiologically would, love to, as I said, postnatal life, the ductus will close. And what are the factors that will close the ductus? Anytime there's an increased oxygen tension, that is why I said increased PaO2 is the most important and significant factor that will lead to the closing of the ductus. Number two, bradykinin and acetylcholine. In our MBBS levels, we are only talked of PaO2, but trust me, when you read books like Nelson, when you read books like Park's Cardiology, you'll always find these two things which are coming in, bradykinin and acetylcholine. The increased levels of these two factors will also lead to closure of the ductus. And a decreased PGE2 levels postnatal. Please mind it, this is a PGE2. The very obvious question that would immediately come up, and why I'm so confident about this is because I had the similar question when I was studying back in my MBBS days, that we say that in utero, it is the prostaglandin E2 levels which keeps the ductus open. However, for circulations which are duct dependent, we always give an infusion of PGE1, that is alprostadil. So always remember it, in utero, PGE2 maintains the ductus. Postnatal life, if we at all need to keep the ductus open for some special duct-dependent circulations, which I'll come to later, it is always the infusion of PGE1, that is alprostadil, that takes over. Okay. Now, aspirin intake in pregnancy, it will close the ductus in utero, which will lead to a persistent pulmonary hypertension in newborn. Very simple. Whenever the ductus is closing, it clearly means that no blood now in utero can move from the right ventricle to the aorta. It will, and because the pulmonary vascular resistance is already high in a newborn, this blood will lead to a hyperdynamic circulation in the pulmonary vasculature that will lead to a persistent pulmonary hypertension in the newborn. What can cause a reopening of ductus prior to closure? Which means in utero, the ductus was open. Now the baby has taken birth and it closed. But within a few hours of closing, it again reopened. What was the first factor that I talked of that is leading to the closure of ductus? It is increased oxygenation, increased PaO2, right? So anytime there is hypoxia, that is a decreased PaO2, anytime there is an acidosis, or as I said, anytime there's a PGE1 infusion, alprostadil, in case given in cases of duct dependent circulations, we will always have a reopening of the ductus prior to its closure. I think that should sum up everything. Talking of pulmonary vascular resistance and its implications, this is the graph which is so important. It's actually a one page that is given in Nelson. I tried to simplify things and bring it here in form of a graph, and give the maximum amount of content in this one slide. So this is a very important slide, especially for the ones who are doing the residency. So pulmonary vascular resistance, as I said, it is high in utero. Can you see the graph? Uh, in a fetal in the fetal life, there's so much high PVR. And why is it? It is due to relative hypoxia. Hypoxia will always cause pulmonary vasoconstriction. This is something which is tested even at the undergraduate level. Anytime there's hypoxia in your body, every other vessel in your body will dilate except the lungs. It is pulmonary vasoconstriction that occurs in response to hypoxia. Why? Why? It is due to the closure of the potassium gated channels. Well, it's a totally different discussion that I don't want to get in right now because of the shortage of time, but I can clearly tell you this. Always remember, hypoxia dilates everything but constricts your lung. So in utero, there's always a pulmonary vascular resistance which is high due to a relative hypoxia. Also, there's an increased smooth muscle in the wall of small pulmonary vessels. There's always an increased smooth muscle, which leads to a high PVR. And as I said, pulmonary circulation is never the seat of circulation in utero, so the lungs never really expand. Due to this non-expanded lung, there is a very high PVR in utero. Look at this graph where I've marked the arrow with birth. Whenever there is birth, at that point, post-birth, you will see PVR starts falling. First, the fall is very rapid. The rapid fall is due to now alveoli start opening up, the lungs become the bed of pulmonary circulation, and suddenly the hypoxia is gone because, as I told you, post-birth the PaO2 increases. Whenever the hypoxia goes away, there's a pulmonary vasodilation which occurs suddenly. The alveoli start to open up, the lungs begin to expand, and due to this mechanical expansion of the lungs, there's a rapid fall in PVR. However, it stabilizes after a while. Around 6 to 8 weeks, this is the time when a second change happens in these pulmonary vasculatures. A remodeling starts happening. What is this remodeling? If you quickly look through, during fetal life in utero, there was an increased smooth muscle wall in the wall of the pulmonary vessels. 6 to 8 weeks post-birth, the smooth muscle thickness starts to decrease, and that leads to some pulmonary vascular remodeling changes, which will further lead to another dip in PVR, after which it attains a steady state, and this steady state is what we maintain throughout life. What is the implication of this graph? What is the point of studying this graph? So the first implication, a large VSD will present with congestive cardiac failure only 6 to 8 weeks after birth. A large ventricular septal defect will never present with cardiac failure right at birth. Why? Because whenever there's a large VSD, the blood which is coming from the left atrium, it first, normally what happens? LA blood goes to LV and LV blood goes to the aorta. That's the usual rule. But whenever there's a large VSD, the LA blood, when it drains into LV, it immediately moves from the LV, it immediately moves to the RV and then to the PA, which means the LA pressure is directly transmitted into the pulmonary artery. Hence, this entire process of the rapid fall of PVR is slowed down. What I mean to say is, suppose you're walking through a congested lane where you already know that there's a lot of vehicles which are stuck in a traffic jam, right? So the resistance of that road is already very high. Now, what will start happen is, when the traffic jam clears out, the resistance to the flow of those vehicles on that road will gradually start falling. This is usually what is observed naturally, that after postnatal life, there's a rapid fall in PVR. But in this case, what happens is, whenever a large VSD is present, the LA pressure is directly transmitted to the pulmonary artery pressure. The pulmonary artery, which was supposed to receive blood very slowly, because postnatal, it needs to open up gradually and receive its blood, suddenly finds a huge pool of blood coming, and it suddenly, what it does is it increases its resistance to the flow of that rapid pressure of blood that is transmitted from the left atrium. Hence, this slows down the rapid fall in the PVR and thus does not manifest congestive cardiac failure. What would lead to a congestive cardiac failure is that too much of pooling of blood in the lungs, and then that blood directly coming to the left atrium and overloading the left ventricle. That is what would lead to a congestive cardiac failure. A large VSD always minimizes this pressure transmission. Number two, while living at high altitudes, infants with high ventricular septal defect do not acquire CCF. However, as they descend towards the sea level, the CCF manifests. Very simple. As I told you, hypoxia dilates everything, constricts your lung. Whenever they are at high altitudes, the relative oxygen saturation, I mean, the partial pressure of oxygen in the atmosphere is low. So a low PaO2 maintains the pulmonary vasoconstriction, thereby maintaining the pulmonary vascular resistance. The moment they descend down to sea level, these, I've had cases where a kid from Kashmir maybe has descended into a Goa, into a place like Goa, and suddenly it was an undiagnosed case of a VSD, and now suddenly the parents are anxious because the child is showing clear, frank features of congestive cardiac failure. So they're always coming in saying that nothing happens when we are, when we were up in the mountains. It's because what saved the child back in the mountains is the relative hypoxia that developed and maintained the high pulmonary vascular resistance. Number three, preterm infants with a severe hyaline membrane disease and a left to right shunt, they do not develop congestive cardiac failure. Nevertheless, ironically, CCF may manifest as HMD improves. Trust me, this is so common in ICUs. My seniors who are attending this, or even people who are my colleagues, my friends who are doing the residencies, you would always notice that whenever there is a case of a severe hyaline membrane disease, usually these kids are preterm kids. Whenever we place them on a ventilator, we are trying to balance their hemodynamics. We are trying to balance their oxygenation. We are trying to balance their diffusion and perfusion, but everything stays fine. We do not have manifestations of CCF. The moment the patient becomes well, the moment the oxygenation of this patient improves, frank CCF-like symptoms start to develop. Again, everything lies in this little hint that I wrote. Hypoxia dilates everything, constricts your lung. Whenever this preterm kid is having a hyaline membrane disease, there is hypoxia, there is a very high pulmonary vascular resistance. This prevents blood from pooling into the left side of the heart, thereby preventing a congestive cardiac failure. The moment you treat hyaline membrane disease, if they're already having a huge left to right shunt, like a large VSD, for example, frank symptoms of CCF will start developing. Okay, having said that, I complete the very basics that I was supposed to talk of, and now we will move into the congenital heart diseases per se, one by one. I'll try to keep this as crisp and short as possible. We'll start off with the cyanotic diseases first. What I mean by cyanotic is predominantly there'll be shunt from the left to the right side. It can be at the level of the atrium. It can be at the level of the ventricles. The entire thing being that left to right shunt will occur. A large amount of blood will move in from the left side of the heart to the right side. That means it will move through the pulmonary artery. So these children will always present with, number one, a pulmonary plethora. What do I mean by pulmonary plethora? Whenever a large amount of blood moves in through the pulmonary artery, it leads to an X-ray appearance, which we'll see with the individual X-rays. This is called a pulmonary plethora, where the large amount of blood is reaching the lungs. Because a large amount of blood reaches the lungs, it also pushes that much amount of blood back into the left atrium, and the left atrium moves it to the left ventricle. So in all of these kids, we will predominantly have a cardiomegaly, which is involving the left-sided chamber enlargements. And thus, because the left ventricle suddenly starts getting dilated, receives a huge amount of blood all at once from the pulmonary circulation, frank symptoms of CCF are very, very common in cyanotic
ये
diseases.
दवा जब भी खाओ
There will be no
तो सुबह
cyanosis.
मील के साथ, समझे?
There will be no.
शाम को नहीं।
नहीं, हमने सोचा जैसे नाश्ता करके वापस आएगा तभी खाएंगे।
नाश्ते के साथ ही कर लो, क्योंकि डाइल्यूट होता है वो खाने के साथ, हजम होता है।
I think
ब्लड में जाता है।
someone
रात को
who is
मत खाना, क्योंकि रात को
unmuted.
उसका फिजिकल एक्सरसाइज होता नहीं, तो जम जाएगा, मतलब निकल जाएगा सुबह में।
Is there anyone who is unmuted? Can you please mute everyone who's in this meeting? It's just a humble request. Please mute your mics. Okay. So as I was speaking, that anytime there's a left to right shunt, there will be a lot of blood that will move into the pulmonary circulation, and that will be again brought back to the left side of the heart, and the left-sided chamber enlargements will happen. Because of the left-sided chamber enlargements, these kids will present with frank CCF-like features. There'll be pulmonary plethora, which you'll find on X-ray. Okay, so let's dive into the individual cyanotic heart diseases. We start off with this thing, which is a VSD, which is the ventricular septal defect. It is the most common congenital disease overall. And in fact, it is the most common congenital disease in the infant of diabetic mother. Infant of diabetic mother is such an important topic for people who are preparing for your entrances. Please, please, please take a note of all the common congenital heart diseases, the most specific congenital heart diseases, the other congenital defects that can happen in infant of diabetic mother. Okay, what are the types of a VSD? If you can clearly look into this diagram, you have a membranous VSD, which is also called a perimembranous VSD, which forms almost 50 to 70%. And you can see it occupies the posterior-inferior part of the interventricular septum. And usually, they constitute the majority of the VSDs that we come across. The second one is a muscular VSD. And what is the important part about this muscular VSD is they'll close spontaneously by 4 years. Amidst this muscular VSD, we have another part, which is a trabecular, which forms under the muscular VSD itself. This is also called a Swiss cheese type appearance. You can see this cute cherry holding the Swiss cheese, exactly appearing like this. But the problem is, as I said, muscular VSDs usually close spontaneously by 4 years, but the Swiss cheese type or the trabecular subtype, it does not close, so it's very, very difficult to manage. It's having one of the worst prognosis amongst the other VSDs. The other one, which is an outlet type VSD. It's also called a supracrystal VSD. It's a rare form, but it's a severe form. As you can see, that part of the ventricle is where the aorta, is in a close vicinity. So anytime there is a supracrystal type of VSD, it can be associated with an aortic valve prolapse or an aortic regurgitation. These are points that have been predominantly asked in your super specialty exams, entrance exams. Please, please, please do take care of this. Let's look at this X-ray. Can you see? So this X-ray is a classic X-ray of an cyanotic disease, a left-right shunt, where you can see a complete left-sided chambers are enlarged. There is cardiomegaly, there's pulmonary plethora. You can see when we deal with cyanotic heart diseases and we deal with pulmonary oligemia, you will see how black those lung fields are. You can see so much of pulmonary of bronchovascular markings here, which shows there's so much of blood which is moving into the pulmonary circulation, and thus those blood is getting back into the left side of the heart and causing those left-sided chamber enlargements. This is an echo, which is just showing the defect between the left ventricle and the right ventricle, which most commonly is nothing but a ventricular septal defect. Now, talking about the hemodynamics, this is a very nice flow chart that I found out. And I wanted to talk to you about what happens usually when there is a small VSD, not a very large VSD. So what happens is usually your left ventricular pressure is the systole is around 100, the diastole is around 12, and the right ventricle is having a systole by diastole around 20 by 8. So what is the gradient? 100 minus 20 is 80, and 12 minus 8 is 4. So it's 80 by 4. Whenever there is a delta P, or whenever there is a pressure gradient more than 12, anytime there is a pressure gradient between a defect which is more than 12 millimeters mercury, the blood hence directly goes from the left ventricle to the right ventricle. This blood moves from the right ventricle, but it does not stay in the right ventricle. It directly drains into the pulmonary artery, which is coming from the right ventricle. Hence, the RV size remains normal. This is such an important point. I repeat that because of this pressure gradient, the left ventricle drains its blood not into RV, but directly into the pulmonary artery. So the blood does not stay in the RV for a long time, which is why the right ventricular size remains apparently normal. As I said, the manifestations of the clinical features of congestive cardiac failure happens around 6 to 8 weeks. It is because of the fact that because of this VSD, the fall in pulmonary vascular resistance is a little less as compared to the other kids who are not having a VSD. Hence, frank manifestations of CCF never occur at birth. So anytime you are having a kid with a CCF right at birth, the first thing that you often rule out is VSD. It cannot be a VSD. Okay, there are murmurs. Now, whenever we talk of murmurs, one thing is a murmur that is happening due to the shunt, which is the shunt murmur. That's the shunt between the left ventricle and the right ventricle, which is going to be a pansystolic murmur. It's no brainer. The moment the left atrium drains its blood into the left ventricle and the left ventricle starts contracting, entirety of the blood will move from the left side to the right side, hence leading into a pansystolic murmur. This murmur is also called a Rogers murmur. What do you mean by a flow murmur? What is a murmur? Basically, whenever I'm talking of a murmur, I mainly mean that either a huge amount of blood has to flow in through a narrow space, or there has to be a significant amount of obstruction to that flow of blood. That is exactly what causes a murmur. Either a huge amount of blood flowing through a normal sized orifice, or a constricted orifice not being able to regulate the blood and thus causing turbulence. These are the two causes of a murmur. In this case, there'll be a flow murmur because a lot of blood will directly move from the left ventricle to the pulmonary artery. So because of this, you have an ejection systolic murmur of the pulmonary valve. Also, you realize that this the blood which is moving to the pulmonary artery, they'll ultimately, via the pulmonary veins, they'll come back and drain into the left atrium. Whenever they're draining into the left atrium is suddenly overwhelmed by a huge pool of blood, which it has to now send through a mitral valve. That will lead to a mid-diastolic murmur at the mitral area. That explains the two types of murmurs that we have. Having said that, whenever the pressure gradient is so high that the LV is directly transmitting the blood into the pulmonary artery, these are the conditions where the QP is to QS ratio. What do I mean by QP? That's the perfusion of the pulmonary circulation is to the perfusion of the systemic circulation. Anytime the pulmonary circulation is receiving double the amount of blood of the systemic, this is considered as an ominous sign. It is one of the signs which should indicate a need for a surgical closure of the shunt. Correct. So murmurs we know. A shunt murmur, which is the Rogers murmur, the pansystolic murmur, which is found, the flow murmur, which is due to the flow through those individual valves. You have the ejection systolic murmur at the pulmonary valve, the mid-diastolic murmur at the mitral area, which is due to the excess blood that the left heart is receiving from the lungs. And because of this thing, the huge amount of blood that it's getting, usually what do we mean by a second heart sound is an A2P2. The aortic component always comes first, then comes the pulmonary component. Do you realize there's so much of blood which the LV is directly draining into the pulmonary artery? The pulmonary valve takes a little longer to close, thereby leading to a wider gap, wider split between the A2 and P2, leading to a wide split S2. No brainer, which is the side of the heart which is enlarged. It is always the left sided chambers which are going to get enlarged because of the bulk of the circulation from the lungs that will come into the left side through the pulmonary veins. So the ECG will strictly show me a left axis deviation. Now, what do I mean by a severe shunt? There are two factors which will determine my shunt severity. When I say shunt severity, number one is the shunt size. The size is something which is very important, but even more important is the pulmonary vascular resistance. These are predominantly the two factors which will talk to me how severe that shunt is, how severe the symptoms are going to be, and how severe is the possibility of this entire VSD turning into something which is called an Eisenmenger syndrome. What is Eisenmenger syndrome? In all of this condition that I talked of, there was a predominant left to right shunt, which means it was completely an acyanotic lesion. The right-sided deoxygenated blood was never really coming into the systemic circulation. Hence, there was no cyanosis. Now, when I have a very significant shunt size and a very and a PVR which is very severely deranged, so that the blood flow through the pulmonary artery after a certain point of time becomes overwhelming for the pulmonary artery to deal with. What happens is the pulmonary artery starts undergoing some vascular remodeling. Whenever this pulmonary artery starts undergoing vascular remodeling, now this much amount of blood that was moving into the pulmonary artery is restricted, which means the PVR suddenly starts to rise. Whenever there's a rise of pulmonary vascular resistance, the right ventricle, which is exactly the chamber which is behind the pulmonary artery, starts to have something which is called a concentric hypertrophy. It's a pressure-driven hypertrophy which happens in the right ventricle because of the back pressure that is generated from the pulmonary artery, which is now having a very high vascular resistance. Whenever the RV starts getting hypertrophied, the shunt which was earlier left to right now reverses and moves in a right to left direction. And we know this, whenever there's a right to left shunt, the deoxygenated blood will now mix with the systemic circulation and lead to cyanosis. So this is what we call an Eisenmenger syndrome. It's a very ominous sign. We'll talk about it in the next slide. But what are the features that suggest an impending Eisenmenger? So as I told you, the moment there is a pulmonary vascular resistance which is high, or a large amount of blood which is flowing in through the pulmonary artery, and it's an uncorrected defect. So anytime there's pulmonary arterial hypertension, clinically we find it in the form of a parasternal heave. On auscultation, we can get a loud P2. We can also get a parasternal heave, which is found on 2D echo. We can have right axis deviation because the right ventricle now will become hypertrophied, will start getting hypertrophied in response to the back pressure that is generated in the pulmonary artery. So any right axis deviation in a patient of earlier LAD, I mean a VSD patient who was earlier having left axis deviation, now on a recent visit has started to show me right axis deviation. Or on echo, I find a right ventricular wall getting thicker in an already known case of VSD. Or on auscultation, I am finding a loud P2, or there's a parasternal heave, or the 2D echo is showing me clear signs of pulmonary arterial hypertension. These are warning signs, these are ominous signs that this is a need for me to operate, close the shunt, keep the kid safe, because these kids, once they develop Eisenmenger, is going to be very, very, very poor prognosis. In fact, apart from recent articles which have come up, which says that Eisenmenger, it was always thought that Eisenmenger is something that we cannot treat. We will unfortunately lose the kid if the kid is developing Eisenmenger. Of course, of late, there are a few articles which are coming, which I was just reading an article 2, 3 days back, which was saying that is Eisenmenger the end of the road? No, there are some procedures which are being thought of, but still we are not yet definite about treating Eisenmengers. So before you have Eisenmengers, it's always, as they say, prevention is better than cure. So moving into the complications, I already talked of the Eisenmenger syndrome. I've just summarized it in the form of flowchart. The left to right shunt, which causes an increased pulmonary blood flow, certainly leads to vascular remodeling, the pulmonary vascular resistance increases, and the shunt reverses. Earlier it was an L2R shunt, now it becomes a right to left shunt, leading to Eisenmenger syndrome. You can clearly see this. This is scubbing, this is cyanosis. And if you can see, look at this X-ray. This, you can see the lung fields. Just give me a minute. Yeah, you can see the lung fields here, and you can see the lung fields here. How dark these lung fields are, which means that the pulmonary blood flow has reduced because of a high pulmonary vascular resistance. You can also see an enlarged pulmonary artery. If I can mark for you, let me see. You can also see a pulmonary artery which is enlarged. You can clearly see it, which is bulging out. That is the main pulmonary artery, which is bulging out. And this is due to the remodeling changes that have happened due to Eisenmenger. Clearly, if you can see the ECG was finding tall R waves found in V1, V2, V3, clearly showing right axis deviation. Okay, so all of this, bad signs, really bad signs. And what to do once I'm having an Eisenmenger? What to do? Really nothing. What can we do when I'm finding an impending Eisenmenger? That is a very, very, very crucial time that I need to think of a surgical closure. What is the surgical closure? It's a transcatheter device closure. uh, Anytime there's a failed medical management, I will try to operate within six months of age. These timelines are extremely important for your super specialty entrances if you're targeting that for your undergrad level and for your PG entrance. The timelines are not really that important, but you can always have a quick look at it. So anytime there is a failed medical management in a case of VSD, better to operate within 6 months, because later these kids will have Eisenmenger. Any child 6 to 12 months old with pulmonary arterial hypertension, even if it's asymptomatic or medically controlled, please go by surgical closure. Anytime, as I said, QPs to QS more than 2:1. That means the pulmonary circulation is receiving double the amount of blood that is present in the systemic. More than 2 years old, please go with surgery. And anytime there's a supracrystal VSD of any size, it is always better to go. Why? I clearly talked of anytime there's a supracrystal VSD, it will always be associated with other valvular anomalies like aortic regurgitation, aortic valve prolapse. And what is the most common complication post-surgery? It is the right bundle branch block. Okay. 30 to 50% VSDs, they'll close by 4 years of age, I told. Out of these, 80% are muscular. I previously have talked of it. The only one that does not close, which in spite of being a muscular VSD, I talked of, is the switch cheese type of VSD, which is the trabecular form as well, which is a very poor prognosis. The membranous VSDs do not close after 5 years. The muscular VSDs do not close after 8 years. Two straight lines from Park's textbook of cardiology, one of the predominant standard textbooks that we read in pediatrics. Having said that, we enter into the next spectrum, which is an atrial septal defect. And whenever I'm talking of an atrial septal defect, now it has a predominantly a female preponderance. There's almost double the cases of females that we encounter. So the first things first, this is especially for the ones who are in undergrad level. Once you find a patent fossa ovalis, it is not an ASD. Anytime there's a fossa ovalis, it is completely benign. In fact, most of the times you don't require any investigations for a patent fossa ovalis. It will either automatically close with time or it will not lead to any problems. So when I talk of atrial septal defect, I am not meaning a fossa ovalis. Okay, now when I talk of an atrial septal defect, I predominantly have the four types of atrial septal defect. The first one is the ostium primum, which actually does not come as an isolated entity. It comes as a part of endocardial cushion defect, which is associated more with a syndrome, which is a trisomy 21 or a Down syndrome. It leads to conduction defects, mitral regurgitation. But whenever I talk of ASD, what I predominantly mean, 70% of ASDs are actually comprising of this complex, which is an ostium secundum complex. And this ostium secundum complex is what is usually associated with a mitral valve prolapse and partial anomalous pulmonary venous return, or a PAPVC. Okay, so the third type is a sinus venosus type, which is close to the opening of the the RA into the of RA into SVC and the RA into IVC. Anywhere near the junction of the superior vena cava and the right atrium, or the inferior vena cava and the right atrium, you can find this type of sinus venosus type, and the other one is the coronary type. But when I talk of ASD from now on, next 5-6 minutes, I'll predominantly be meaning the ostium secundum type. Some associations have been previously asked, very important at your residency level and your super specialty level. So majority are sporadic. Strong association has been found with Hall-to-Ramp syndrome. What is Hall-to-Ramp syndrome? These kids will have associated limb defects, limb hypoplasia and limb defects, and it comes as an autosomal dominant inheritance. This is a question which has been asked at all forms of entrance, both super specialty as well as for PG entrance. The gene has been asked in super specialty. This TBX5 gene on chromosome number 12q21. And as I said, it is associated with trisomy 13 and 18. Whenever there's an ostium primum type, which is a part of endocardial cushion defect, it is associated with Down syndrome, that is trisomy 21. Unlike VSD, where the pressure gradient was almost around 80/4, here the pressure gradient is not really significant. As you can see, it's 8/0 and 3/0, which makes it the pressure gradient is around delta P is 5. Anything, as I said, anything less than 12 millimeters of mercury, pressure gradient which is less than 12 millimeters of mercury, will never produce a significant shunt, which is why you will never get a shunt murmur really. What you only get is a flow murmur, because a large amount of blood is flowing in from the right atrium to the right ventricle, and from the right ventricle into the pulmonary artery. So you will have a mid-diastolic murmur at the tricuspid area and an ejection systolic murmur at the pulmonary area. As I said, no shunt murmur, because the pressure gradient is not enough to create a shunt murmur. What I mean is, when I say a large ASD, the shunt is usually silent, and this is because the RV wall is comparatively thicker in cases of in case of fetus. The RV wall is comparatively a little thicker, and it is a low compliance. In fact, let me tell you, ASD is one of those diseases which never becomes symptomatic when the kid is when the child is young. It usually presents around 20 to 40 years of age. That is when the pulmonary vascular resistance really starts to fall, and you have signs of those classic signs of failure to thrive, or you have recurrent pneumonias. In fact, most of the patients of ASD initially are diagnosed as recurrent pneumonias in between the age of 20 to 40, and later on echo we do find a large atrial septal defect. So it's if you're asked what is one congenital heart disease that you really want to have, I mean, ideally you would not want to have any, but if you really want to have one, it's better you get an ASD, because it usually stays very silent, and by the age of 20 to 40 you will start manifesting, and it's also a relatively a lesser notorious disease than the other diseases that we will usually talk of in the flow of the discussion. What happens to the A2 and the P2? So S2, as I said, it's A2 and P2. There'll be a lot of blood that will be moving from through the pulmonary area, so the pulmonary valve will take a little time to close, and there will be a wide split. That is clear. But what is this fixed split? The fixed split is because normally the split between A2 and P2 physiologically will depend on the cardiac cycle. It will depend on your inspiration and expiration. There'll be a variation in inspiration and expiration. There'll be a variation during cardiac cycle. But just imagine, every blood that the left atrium is getting, it is just shunting it right away into the right atrium. There's no variation with the cardiac cycle. There's no variation with inspiration, expiration. So this split that you find, A2 and P2, the wide split that you find, remains fixed. It is irrespective, indeterminate of the cardiac cycle. It's indeterminate of the inspiration and the expiration patterns of the patient, which makes it a wide fixed split S2. Please remember this, wide fixed split S2, because anytime you have an acyanotic disease, an acyanotic congenital heart disease with a wide fixed split S2, it is atrial septal defect. Anytime you have a wide fixed split disease, but a wide fixed split S2, but in a cyanotic congenital heart disease, it is TAPVC. This is another MCQ which has been tested in your super specialties as well as in your PG entrance exams. So wide fixed split S2, ASD in an acyanotic case, and TAPVC, there is total anomalous pulmonary venous circulation in the cyanotic case. A presence of mid-diastolic murmur at the lower left sternal border, that is the tricuspid area. It will indicate that this is a hemodynamically significant ASD, which means a lot of blood is pooling in, a lot of blood is going into the pulmonary circulation. Again, simple, QP is to QS more than 2:1, and hence requires a prompt closure. because the right side here in this case, the right side will show a predominant enlargement. The LA is receiving whatever blood the LA is receiving is just shunting it right to the right side. So the right sided chambers will be enlarged. The ECG will show me a right axis deviation, except in ostium primum variety, which I said is more associated with Downs, more associated with endocardial cushion defect. It is only the ostium primum ASD which will show me a left axis deviation, and the reason to it is the left anterior fascicular block and a mild mitral regurgitation, which we find in those cases. The explanation is not really required at your level, but one thing you can remember, ASD is usually right axis deviation because the right sided chambers get enlarged, except the one which is ostium primum, which is having a left axis deviation. What happens in the 2D, though, this 2D finding is something which is something which is mentioned in Nelson, which I really wanted to pick it up. So it says it's a paradoxical motion of the interventricular septum. What happens is during you and me in a normal person during systole, the interventricular septum usually moves posteriorly, but in an ASD, because of the overloading of the right side of the heart, the interventricular septum will actually have an anterior movement. So this paradoxical movement of the interventricular septum during systole is which is something which is diagnostic and found in cases of ASD. The complications are very simple, just like VSD also, like even anytime there's a left to right shunt, trust me, even in VSD, you'll find recurrent infections, you'll have recurrent pneumonias, you'll have in fact infective endocarditis because of the large amount of blood which is pooling into those through those valvular areas. So infective endocarditis is very common, in fact, in VSD. In ASD, you don't have that much of infective endocarditis; it's almost absent. And as I said, if you need an ASD, if you need a congenital heart disease, always wish that you get an ASD because the patients remain asymptomatic till adulthood. The pulmonary arterial hypertension may develop later, and it's only that when these patients present with recurrent pneumonias or they present with right atrial arrhythmias, because the left right shunt is clearly causing a dilatation or an enlargement of the right sided chambers. Whenever there's an overstretching of the right atrium, we do find right atrial arrhythmias, and it's only that when these patients are presenting with the recurrent episodes of all of this do we get to see that these patients on echo are having something like an atrial septal defect. Okay, what are the indications of closure? It's very simple. Anytime there's a right ventricular enlargement, anytime there is a QPs to QS, which is more than 2:1, or anytime there is a symptomatic ASD, the time of closure is usually 2 to 4 years of age. Anytime there is a high pulmonary vascular resistance, it is always a contraindication for device closure. Anytime there is a high pulmonary vascular resistance in a left to right shunt, it is a sign of impending or it's a sign of Eisenmenger. And it's always said that whenever the patient has turned into an Eisenmenger, please do not try doing a surgical closure. If at all you need to do a closure, you do it by a especially for the sinus venosus types, you go with autologous pericardial patch repair. Otherwise, in all other cases, like ostium secundum, you can go with a transcatheter device for closure. Talking of this disease, which I gave a brief overview about in my initial slides of fetal circulation, this is a patent ductus arteriosus. You can clearly see that there is a clear joining in between the aorta and the pulmonary artery, and the ductus is actually joining the pulmonary artery to the aorta. During the fetal life in utero, the blood is always shunted from the right side to the left side because pulmonary vascular resistance is very high. But once the child takes birth, once it's a neonate, because of the high systemic vascular resistance, a large amount of blood will now start moving from the left to the right side, and thus because of the L2R shunt, there will be an acyanotic presentation. The origin of the ductus is usually 5 to 10 millimeters distal to the origin of the left subclavian artery. We usually know that the ascending aorta will divide into 3 branches, right? The brachiocephalic trunk, the common carotid, and the left subclavian. Beyond just distal to the left subclavian, you will have around 5 to 10 millimeter distal to it. You will have the patent ductus. What are the risk factors? Hypoxia, acidosis, high pulmonary vascular resistance, which is secondary to vasoconstriction. As I told you, hypoxia dilates everything but constricts your lung. And a very, 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 very famous question, a congenital rubella syndrome. So if you are asked what is one infection that leads to a PDA, it is always rubella. So what happens basically is these are the risk factors for PDA. And often a question is asked is, why is the ductus open? Why is the ductus open in preterm babies? Why is the ductus open in low birth weight babies? Now, the opening of ductus or the patent ductus arteriosus in case of a neonate who is term and the neonate who is preterm, the mechanisms are really a little different. Although the presentation is almost very similar, the mechanism is a little different, and we'll talk about it. So what happens is whenever there's a preterm baby, in preterms, always remember the structure of the ductus is normal. What happens is the sensitivity of the smooth muscle in the wall of ductus to oxygen is reduced. I told you the ductus closes only, the only stimulus for the closing of ductus is an increase in PaO2. But what if the smooth muscle of the wall of the ductus is not sensitive to that? Because of this reduced sensitivity, there will be a reduction in in the time of closure of the ductus, leading to its patency. So that is why PDA in preterm presents more dramatically with CCF. Okay, and it shows a higher spontaneous closure, which is facilitated by medical management, and it is a very good response to medical management, because the problem is not per se in the structure of the ductus, it's only in the sensitivity of the ductus wall to the smooth muscles. So you give medical management drugs, which we'll talk of right now, indomethacin, ibuprofen, anything, any NSAID that you give, it will close the ductus, and this medical management is best before 14 to 21 days age, and it's successful up to 8 weeks. Nelson says that you can do it up till 8 weeks. So up till 8 weeks you can always try medical management, provided that the other hemodynamic features of the child is maintained. In term babies, however, the ductus artery, the anatomy of the ductus is what is a little problematic. It is deficient in tunica media, it's deficient in the endothelial layer, which is why it will not close spontaneously. And because here, sensitivity is not the issue, the per se anatomy is the issue, you will have a very poor response to medical management. What do I mean by medical management? There are two drugs which are tried. Just the name of the drugs, indomethacin, ibuprofen. Theoretically, we were always saying indomethacin, but recent trials will always show you that ibuprofen is better. Why better? Because ibuprofen, first of all, was oral, number one. Number two, ibuprofen has less risk of oliguria, which indomethacin has. And the most important thing that I'll say is, as Park's pediatric cardiology says, that ibuprofen reduces the risk of necrotizing enterocolitis, which indomethacin does not. Indomethacin has a neutral role in necrotizing enterocolitis. It neither increases the risk nor decreases the risk. But now here you have a drug, because any preterm is very predisposed to develop necrotizing enterocolitis. Anytime you are having a preterm who is at a risk of NEC, always prefer ibuprofen. Less oliguria, less chances of renal failure, less AKI. But the only one thing where indomethacin, kind of gets ahead is the reduction rate in the risk of intraventricular hemorrhage. So basically, ibuprofen will not reduce the risk of IVH, but indomethacin will do. But if you still ask me what's better, it's always ibuprofen better. Here I want to talk of recent AIMS protocol, which is talking of the drug called paracetamol, acetaminophen. It has shown results. It has shown to be equally efficacious, but it has not yet been approved. So if in a question, in a clinical vignette, you don't have any other option like indomethacin, like ibuprofen, you just have acetaminophen or a paracetamol, you can go with that option. But trust me, it has not yet been approved, because paracetamol in neonates, paracetamol has been shown to have a very high association with autism spectrum disorder. So my colleagues who are probably researching in psychiatry or neuropsychiatry will be able to give more light on this. But acetaminophen use in a neonate is preferably not allowed, because of the risk of those kids becoming autistic later in life. Now, the manifestations, as I said, it's predominantly L2R shunt, and as I told you, a neonate with hyaline membrane disease, you treat him with surfactant, you put him on the ventilator. The PDA is silent, because the pulmonary vascular resistance is very high. Because of this, the PDA will usually remain silent. As the hyaline membrane disease will improve, as the hypoxia will improve, the PDA will start to manifest, because, as I said, hypoxia is something that will lead to the opening of the ductus. Whenever hypoxia is there, the PDA will be there, but then as the HMD will improve, the PDA will manifest as difficulty in weaning off the ventilator. So any kid whom you are suspecting as a preterm kid with hyaline membrane disease, and you're having a difficulty in weaning off the ventilator, you should always consider a PDA which was earlier silent and is now manifesting, and it'll lead to a high PaCO2 levels, which manifests as a type 2 respiratory failure. You get something which is a bounding pulse. Now, for explaining this bounding pulse, I want you to look very carefully at this image. So what happens basically is post birth, what is happening is, because of the patent ductus, now the flow is now from the aorta to the pulmonary artery. Now, the lungs are receiving a huge amount of blood, which they are pooling into the left side of the heart, and the left ventricle is receiving a large volume, which is the preload. And by Frank Starling law, the more the preload, the more is the the more is the contractility. So the ejection fraction goes up, the systolic BP goes up. So the systolic BP is always high because the left ventricle is receiving a large amount of preload. What happens to the diastole? Now, diastole basically is a component of the elastic recoil of the aorta. As you can see, a lot of the blood will not be moved into the aorta, but it will move right from the aorta. It will be shunted directly toward the pulmonary artery, which means less amount of blood in the aorta will make sure that there is less elastic recoil by the aorta. So systolic BP is more because of increased preload to the left ventricle. Diastolic BP is less because of less elastic recoil, because there's not a lot of blood volume in the aorta. This high systole and a low diastole is what will lead to a wide pulse pressure, and this will cause bounding pulses, which is clinically very significant in cases of PDA. Anytime you are finding a congenital heart disease with bounding pulses, close your eyes. If it's cyanotic, it is PDA unless proved otherwise. Because there will be a continuous flow from the aorta to the pulmonary artery into the lungs. There'll be a continuous machinery murmur. It'll sound like literally a machine. You should just go up to YouTube maybe and search the sounds of these murmurs, because today we are not really having much of clinical examination and understanding as to how or what exactly a murmur sounds like. It's always better that you once get a hack of how it sounds like, so that when you see your patient, when you auscultate your patient, it becomes a little easier for you. So there is a continuous machinery murmur which is found at the second left intercostal space. There will be a low urine output, and why low urine output? Because aorta is not receiving much amount of blood that it will send to the systemic circulation. So the major organs like the kidneys, the mesenteric areas, they will be deprived of blood, and there'll be a narrow split S2. A2P2 is what we call as S2. Whenever the aorta is quickly sending the blood to the pulmonary artery, and it's moving, both the aortic valve and the pulmonary valve will close a little. The aorta will close a little later, the pulmonary valve will close a little earlier, and that will lead to a narrow split S2. So that is what is the clinical manifestations of PDA. When I talk of PDA complications, any left to right shunt, I said any left to right shunt may develop an Eisenmenger syndrome. In fact, Eisenmenger syndrome in PDA is more dangerous than VSD. In VSD, it takes some months to develop, but in PDA, because of the component of pulmonary arterial hypertension, the Eisenmenger is often likely to develop earlier than a VSD. You find a differential cyanosis. Why this differential cyanosis? It's very, very easy. So if you can see in this diagram, you have three arteries, which are three vessels which are originating from the ascending aorta. The first one is the brachiocephalic trunk. The second one is the common carotid, and the right one, the next one is the left subclavian. And distal to the subclavian, you are having this patent ductus arteriosus, which means that the upper limb is receiving a good amount of oxygenated blood. The lower limb, however, is deprived of blood, and thereby you will find a differential cyanosis that may occur in cases of PDA. There'll be a difference in the blood. You will also find that the upper limb is usually pink, the lower limb, the toes, you usually will be having blue, and they'll be showing cyanosis, and they may show clubbing at some time, whenever especially the pulmonary arterial hypertension has exceeded its normal limits. There'll be recurrent pneumonias, just like in any left to right shunt. There'll be recurrent pneumonias. There'll be failure to thrive. There may be features of CCF, and one of the complications, which is rare, but it's a very, very serious complication, it's an aneurysm in the wall of the ductus arteriosus, which can lead to rupture and sudden death in these individuals. Management, very simple. If it's a preterm, try doing medical closure. And there are some contraindications for medical closure, like you have thrombocytopenia, where the platelet count is less than 1.5 lakhs, polyuria, or raised serum creatinine, which will show features of AKI. Anytime there is an active NEC and active IVH, please note I said that ibuprofen reduces the risk of NEC, but once NEC has developed, once IVH has developed, there is no point of trying a medical closure. You'll straight away shift to surgical closure. Surgical is again via the transcatheter approach, and you just do a basic coiling of that ductus to shunt that, to prevent the shunting of the blood. And the most common complication is a post-ligation syndrome. What is it? It's basically a sudden drop in BP, which is 6 to 12 hours post-ligation. It's seen in almost 50% of low birth weight babies. It's a post-ligation syndrome, which is easily managed by conservative therapies. It does require a bit of inotropes, IV fluids. Everything is good. Concomitant use of indomethacin and hydrocortisone is contraindicated. It's a pharma update. Please do not use these two drugs together, because they'll increase the risk of intestinal perforation. In any way, I said you that indomethacin does not protect you from NEC, and ibuprofen does. An update which has been added in the AIMS third edition is Some biomarkers which have not yet been proved, to be honest, but exciting results have been found. Troponin T, atrial natriuretic peptide, the brain natriuretic peptide, they have shown exciting results. The most common echo parameter to determine a PDA is the diameter of the ratio of the diameters between the left atrium and the aorta. As I said, the monitoring in PDA, you should always try and ensure that there is no oliguria, no AKI. So daily urine output, alternate day RFT, and platelet count. Anytime the platelet count is less than 1, please be careful about switching over from medical therapy. And anytime, so what we usually do is we will monitor 3 days during therapy and 3 days after. So that is exactly how we monitor. The last, the cyanotic disease that I'll talk of is the coarctation of aorta. And when I talk of coarctation of aorta, I'll predominantly again lead you to this diagram. So as you can see, there is a clear coarctation that you find. There are three points of coarctation. The one is the juxtaductal. What I mean by ductal is the ductus arteriosus. So just at the opening of the ductus arteriosus, you will find the most common form of coarctation of aorta. Anything which is before it is preductal, anything after it is postductal. And why does a coarctation develop? It may be due to the abnormal extension of the contractile ductal tissue into the aortic wall. And the second thing may be because there's a decreased anterograde blood flow through the aortic valve in fetal life. We might have a case where there will be a coarctation of aorta developing. Mainly it's the first one where a contractile ductal tissue is somehow trying to invade into the wall, which is why even during surgical management, our first thing is to cut that piece of tissue, which is called a coarctectomy. Coarctectomy is cutting that contractile piece of ductal tissue which is in vicinity to the ductal wall. Associations, mainly Turner syndrome is what undergraduate students, you can remember this. Bicuspid aortic valve, very, very important. But for the ones who are doing the residency and the super specialty, there are two complexes, Face syndrome and Schoen complex. You really don't need to understand what are exactly the individual things of Schoen complex. But in case you do, I have the slide there. You can quickly look through it. Face syndrome and Schoen complex are the two things which is also associated with the coarctation of aorta at undergrad levels. Males, Turners, and bicuspid aortic valve, which is almost having a 70% association, is enough. As I said, you can see a contractile piece of tissue, which is just very close to the ductus. In fact, it's a juxtaductal variety. And as I said, that in utero, the circulation is usually ductus dependent. So you can see, because the ductus is patent in utero, these kids will never manifest. They'll be silent in utero. Postnatal, once the ductus closes, you can clearly see beyond the left subclavian, there is no blood that can flow, which means that the lower limb will be devoid of any blood supply. Because of this, you will be having a low blood pressure in the lower limb. The lower limb is devoid of blood supply due to the descending aorta not receiving blood. The descending aorta is also going to end up in the abdominal aorta, and that will be supplying the mesenteric areas, the renal areas. So there will be oliguria, there will be metabolic acidosis, there will be mesenteric ischemia. The kid may just complain of a frank pain in the abdomen with a decreased, lower limb pulses. A lower limb BP is reduced. There'll be a frank difference between the BP of upper limb and lower limb. Okay, so you can clearly see the upper limb is going to receive plenty of blood by the three structures which are arising from the ascending aorta, whereas the lower limb will be devoid of its blood supply. Again, because the duct was actually saving these kids, it's a duct dependent circulation. This duct dependent circulation in an acyanotic disease, you should always think of coarctation of aorta. What we will do, we cannot immediately go for this coarctectomy. We cannot immediately cut that piece of those contractile tissue in an unstable patient. So what we do is, initially we try keeping the ductus open. We give an infusion of IV alprostadil, which is the PGE1 infusion. I repeat, what keeps the ductus open in utero is PGE2. What you give after birth to keep the ductus open is PGE1. So please don't forget this. So we do a life-saving procedure where we are infusing PGE1, and once the kid is stable, we can now take this kid up for a coarctectomy. As I said, initially they'll be asymptomatic unless there's critical coarctation. They'll present with exercise intolerance. They'll present with intermittent claudication. Claudication is pain in the limbs. Just imagine this kid is not receiving blood in the lower limbs. So whenever there is exercise, there's dyspnea on exertion, there's hypertension in lower limb, low BP in the lower limb, hypertension in upper limb, low BP in the lower limb, and there's a clear radiofemoral delay. Again, a no-brainer. The upper limb is receiving blood, the pulses are good, everything is good in the upper limb, almost nothing is coming in the lower limb in case of critical coarctation. There is an asymmetry between even the growth of the upper limb and the lower limb. Can you see this kid? See the lower limbs of this kid, see the upper limbs of this kid. There's clear difference between the USS to LS ratio, and this is again a feature that you may get in cases of coarctation. You might get headache, you might get subconjunctival hemorrhages. These are all features that you get due to raised ICP. Why raised ICP? Because through these three channels, the brachiocephalic trunk, the common carotid, and the left subclavian, a pool of the blood entirely is almost going into the upper limbs and the brain, which will lead to raised intracranial pressures, leading to headache, subconjunctival hemorrhages. Typical 2 X-rays I wanted to show you. First is this, which is a figure of 3 sign. You can see this. This is very classical that you find in case of coarctation of aorta and an inferior rib notching. The inferior rib notching is due to collaterals which develop between the branches of anterior and the posterior intercostal artery between 3rd to 8th ribs. That is something which I have not written in the slide. You can add it down to your notes. It's due to the collaterals between the 3rd to the 8th ribs. Okay. Management, as I said, if you can go with medical management, the first thing that you do is alprostadil infusion. Apart from that, you give infective endocarditis prophylaxis. Any left-to-right shunt will present with can give rise to infective endocarditis, except ASD. ASD usually IE is absent. You manage CCF do conservative management. Once there is stabilization of this kid, you always go in with a coarctectomy. You just resect this narrow segment, and you just re-anastomose the remaining part of the aorta to its original wall. What is the complication? Immediate post-op, you can get something which is like post-coarctectomy syndrome, where there will be acute abdominal pain with anorexia, nausea, vomiting. You can get intestinal hemorrhages. Acute hypertension may suddenly develop because it'll just, the blood vessel needs some time to readjust to its normal flow of circulation. But trust me, this is manageable. It's not something which is fatal. It needs close monitoring, and the age group which shows maximum chances of recoarctation is the infancy. What do you do for a recoarctation? Suppose you've done a coarctectomy, but this child now presents a few months later with a recoarctation. You now do a balloon angioplasty. So a question that was asked is the management of coarctation of aorta, is the management primarily balloon angioplasty? The answer is no. It's always a secondary procedure when recoarctation has happened. There's a differential, which is the interrupted aortic arch syndrome associated with Dye-George. I did not want to enter into this topic because it is more of a specialization topic and more of a topic in residency. Because I'm targeting a wide variety of audience, I wanted it to be as strictly associated to the general audience as much as I could. Now, entering into the field of the cyanotic disorders, and when I talk of cyanotic disorders, there's one disorder. Trust me, if I'm told to pick out one disorder that I would just want to study one night before my exam, close my eyes, take out TOF, study it. So I've tried to keep TOF in details. The rest are all in one slides. Just trying to look at TOF, which is tetralogy of Fallow. Now, I always find students who are at their undergrad levels trying to memorize the components of TOF. Trust me, it's not really something that you need to memorize. It's something which comes just with basic concepts. Just you need to remember one word, that is a subpulmonic infundibular stenosis. That's the only word that you need to remember. What do I mean by a subpulmonic? It clearly means that the pulmonary valve is not usually involved. It's not a pulmonary stenosis. Some way below, a few millimeters below the pulmonary valve, you will have a contractile piece of tissue which has grown and thereby limiting the flow of blood, which is what we call a subpulmonic stenosis or a subinfundibular stenosis, whatever you can call. Pulmonary valve, and trust me, this stenosis is what almost contributes to 80 to 85% of the cases. Pulmonary valve stenosis per se, so the valve being stenosed, the valvular stenosis, is hardly 10 to 15% cases. Mainly it is a subpulmonary stenosis. Now, tell me, what happens whenever there is a subpulmonary stenosis? The blood cannot flow from the RV to the through the pulmonary artery. So what will happen? The back pressure will generate. RV will start getting pressure. It will start undergoing pressure changes. And what is the pressure change? It's a concentric hypertrophy. Whenever there is a concentric hypertrophy due to the pressure changes which are generated, the RV wall starts getting thickened. So first change was subpulmonic stenosis. Second change is RV hypertrophy owing to the back pressure changes. Once the right ventricle has thickened, now because there is also a VSD, the shunt will now move from the right to left side, causing cyanosis. And above everything, there is an aorta which is sitting just above the VSD. So 4 things. Let's quickly sum up. 1, subpulmonic stenosis leading to right ventricular hypertrophy. The presence of a large VSD which is causing the right to left shunt and hence cyanosis. And number 4, an overriding aorta. What do I mean by an overriding aorta? You can clearly see this picture. The aorta is exactly sitting at the level of the ventricular septal defect. This is what I call an overriding aorta, and this is This is what you call as the subpulmonic stenosis. If you can clearly see, the pulmonary valve looks okay, but beneath the valve in that black shaded part is a piece of contractile tissue which is limiting the flow of blood and thereby causing turbulence. Okay, so this is the basic diagram of the hemodynamics, and it is overall the most common congenital heart disease. As I said, most common cyanotic congenital heart disease. It is due to a conotruncal defect, which is an infundibular septum, causing a subpulmonic stenosis, causing a right ventricular outflow tract obstruction. RVOTO is that, right ventricular outflow tract obstruction. Thereby, it will lead to right ventricular hypertrophy, which is concentric drive. A large perimembranous VSD will be there, which will lead to the right to left shunt and an overriding of the aorta. And one thing that I want to tell you, because of this overriding of the aorta, the right ventricle is not draining this blood directly to the left ventricle, but it is draining this blood exactly directly into the aorta. What I mean to say is, left ventricle on systole is pumping blood to aorta. Right ventricle during contraction is also pumping the blood directly to the aorta, which means that the left ventricle is never showing you signs of overload. This is something which is very important. Because the left ventricle is not being overloaded, this is why there is no features of congestive cardiac failure in TOF. I repeat this, why is TOF not associated with CCF? The reason is the aorta is exactly overriding the VSD. So when the left ventricle is contracting, it's pushing blood straight to aorta. When the right ventricle is contracting, through the defect, it is not going to the left ventricle, it's moving straight to the aorta, which means aorta at one point of time receives a mixed blood and a bulk of the blood from both the ventricles. So left ventricle never enlarged, right ventricle hypertrophied, but drains its blood into the aorta, which means no features of CCF will develop in TOF. This is such an important point. Anytime you are getting, as I said, two things, two dictums. Anytime you are getting a CCF at birth, it cannot be VSD. Anytime you are getting a TOF, it cannot have CCF. Very, very simple. So RV drains blood entirely to the aorta, so there is no CCF. And because there is a large perimembranous VSD, do you remember when I was talking of VSD, I told you that the shunt size, if the shunt size is large, there's an equalization of pressure between the right side and the left side. So because the perimembranous VSD is large, what happens is the pressure of the RV is almost equal to the pressure of the LV. Usually LV is having a higher pressure normally, but here, number one, RV is hypertrophied. So naturally, the pressure is a little more, and because of the large shunt, there is an equalization of pressure between the RV and the LV that will lead to a condition where there will be no pansystolic murmur heard of VSD. In VSD, you have a pansystolic murmur, which is throughout the systole. Here in this case, you do not have a pansystolic murmur because of the equalization of pressure gradient. Okay. Now, what are the associations? So let me first talk of the variants, because this is something which is asked at the undergrad level very much. We have one thing called trilogy, one is pentalogy. Trilogy is not removing one component from TOF, so please be a little careful about it. Trilogy is a completely different thing. It is having a right ventricular outflow tract obstruction, which is leading to a right ventricular hypertrophy and an associated ASD. And what is pentalogy? You just add an ASD to TOF, that becomes pentalogy. Okay, mostly it is sporadic 80% of the cases, whereas 15 to 20% cases are associated with Didoth syndrome, Allergy syndrome, and Downs. At undergrad level, I will only want you to know Allergy syndrome as a butterfly-shaped vertebra. That's the only thing that I want you to know. And it can come with pulmonary stenosis. Just remember these two terms, butterfly-shaped vertebra and pulmonary stenosis is what I predominantly mean when a question of Allergy syndrome is asked to you, especially for your PG entrance level questions. Sometimes these TOFs can be associated with MAPCA. So what is MAPCA? It is an anomalous pulmonary circulation, anomalous pulmonary and coronary arteries, which are arising, and they exactly override the place where the aorta is over the VSD. So what happens is, if a TOF is associated with MAPCAs, during surgical opening, there's always a chance that you will cut these MAPCAs, and due to this, there will be a sudden decrease in coronary perfusion that may precipitate ischemic changes in the heart. So you should always be careful about TOF with MAPCAs. How to diagnose it? Whether there is a TOF with MAPCA, it's simple. You just go with an echo with a Doppler. You can clearly find out if there is any abnormal artery which is overriding the area of the ventricular septal defect and the aorta. So you can clearly look at that. So as I said, the time of cyanotic presentation, if it's a severe TOF or if there's a pulmonary atresia, most of the times it is a subinfundibular stenosis. There is no atresia. What is atresia? The valve itself is not there. If the pulmonary valve itself is not there, Then it will be a severe TOF. It will present at the neonatal period. So you just need to start off with alprostadil, which is a PGE1 infusion, followed by emergency surgery. And otherwise, it will usually present between 6 weeks to 6 months with dyspnea of exertion, failure to thrive, clubbing cyanosis, all of this, which dramatically improves on squatting. This is another thing that I want you to know. There are 3-4 dictums that I've always talked to you throughout this session today. One more dictum: any cyanotic heart disease which is improving on squatting is TOF, TOF, TOF. Why? Whenever this kid will squat, what happens is we have a large trapping of venous blood in the lower limb. This will decrease the preload of the venous return to the right heart, thereby decreasing the RV pressure, improving the cyanosis. Number one. Number two, whenever we are squatting, we are compressing our systemic lower limb vessels, thereby causing a high systemic vascular resistance. The total reversion of the right to left shunt now, it will change, and the total shunting procedure, the shunting mechanism will now reduce, thereby reducing the frank symptoms of cyanosis. So anytime the dyspnea, failure to thrive, clubbing, cyanosis, which is improving on squatting. In fact, nobody teaches the child to squat. It is such a beauty of nature. The nature has somehow, instilled this mechanism that the child himself or herself discovers that, oh my God, when I squat, I am feeling better. So the child most of the times will always inevitably by birth they will know this defense mechanism of how to survive, and that's something which is so beautiful to imagine as to how beautifully they realize how to adjust to adverse circumstances. Because often there is a pulmonary stenosis, you will not be able to hear P2. Whether there is a subinfundibular stenosis or whether there is a pulmonary atresia, you will never be able to hear a P2. Mainly it's an A2 which is heard, and there's an ejection systolic murmur which is heard at the lower left sternal border. There's something which I want to tell you. Because of this because of this infundibular stenosis, you're having a right ventricular outflow tract obstruction, right? Whenever there's an obstruction to a normal flow of blood, it will cause turbulence, and any turbulence will lead to murmur. So what happens is, as the degree of obstruction increases, the intensity of the murmur increases. More obstruction, more turbulence, more murmur. And this gradually the murmur increases up till it reaches a maximum point, beyond which obstruction has been so much that no flow of blood can occur across that area. Now the murmur disappears. So once a maximum intensity of the TOF murmur is heard, any further increase in obstruction will lead to paradoxical decrease in murmur. What do we mean? The kid has come to you at 3 months, you've heard a murmur, which is ejection systolic. At 4th month or 5th month, you are hearing that the murmur has increased. Suddenly at the 7th month, you are not hearing the murmur. Please don't be happy. It is an ominous sign, which clearly means maybe the right ventricular outflow tract obstruction has crossed such an extent that no blood is now able to flow through the lungs, and that will lead to pulmonary oligemia. You can clearly see lung fields are dark, black. This is a typical Courain Sabo, which is found on chest X-ray. This concavity that you find is due to the right ventricular hypertrophy, also called a boot-shaped heart, is due to and you can also find this. There's a concavity of the pulmonary artery that you're finding. Why? Because due to the right ventricular outflow tract obstruction, the pulmonary artery becomes, atretic almost in some cases, because there's no blood virtually which is flowing through that. And this upturned apex of the heart is nothing but the right ventricular hypertrophy. This is what I mean when I do an echo with a Doppler. You can clearly see the overriding of the aorta and everything, which is marked with its specific numbers. The 2D echo, as I said, with Doppler is diagnostic. Only whenever you are suspecting pulmonary atresia or you're suspecting MAPCAS will you be able, to do a cardiac catheterization. That is the only indication of a cardiac catheterization or a cardiac CT. That is whenever I'm finding a TOF with a MAPCA. Because as I said, during surgical closure, if I cut these MAPCAs, they will lead to a sudden decrease in coronary blood flow. Because there is right ventricular hypertrophy, I will get a right axis deviation, tall R waves in V1, and because now the atria has to generate much more force to drain its blood into an already hypertrophied ventricle. See, whenever the ventricle is hypertrophied, the atria has to push blood with greater force to push the blood into the ventricles. That will lead to a tall P wave manifested as P pulmonale. Tall P wave more than so you can see this in these leads. Just wait, I think I cannot zoom it more than this. But if it's visible, you can find tall P waves, that is P pulmonale, is found in 25% of cases, and it is due to RA enlargement. In fact, even if you do a JVP tracing, not a JVP measurement, it's a JVP tracing, you may find in some cases a prominent A wave which shows active atrial contraction. Now, Complications are very, very, very important. As I told you, one disease that I will extensively talk of in cyanotic is TOF. So most common manifestation is a cyanotic spell or a TET spell. And I'll talk of this TET spell later. But other complications because of hypoxia, there will be polycythemia. Simple. Hypoxia leads to the kidneys which are generating more erythropoietin, and more erythropoietin is more polycythemia. Whenever there's polycythemia, there will be hyperviscosity, and there can be cerebral venous thrombosis in the first 2 years of life. There can be brain abscess in children above 2 years, parietal more than frontal, and these are mainly polymicrobial infections. It's a straight line from Nelson. It's a polymicrobial infection, and anytime you're having fever, seizures, FNDs, focal neurological deficit, and personality changes. Personality changes. Why do personality changes occur in these kids? It's because of the involvement of the frontal lobe. The frontal lobe is something which takes care of our personalities. So anytime there's fever, seizures, neurological deficits, personality changes which you find in a kid of TOF, you will have to diagnose brain abscess. Anytime, as I said, you might find in long-standing cases, you might have a paradoxical embolus that can occur. What is a paradoxical embolus? So basically, right atrium is kicking blood harder into the right ventricle because right ventricle is now hypertrophied. Because of this entire thing, there will be a time when the right atrium cannot really generate much of pressure. Instead of generating pressure, now because of the extensive right ventricular hypertrophy, the right atrium will start getting dilated due to back pressure changes. Because of dilation of the right atrium, you will find sluggish circulation that may lead to an embolus. Now, this embolus is found in the right side. When it comes down through that shunt, it will move from the right side straight into the aorta, and this embolus will now come into systemic circulation. So initially, a right-sided embolus that developed entering into systemic circulation right now is what we call as paradoxical embolism, and it can also lead to growth retardation. The most important complication that I want to talk of, very, very extensively asked at undergrad level, also at residency level, is a TET spell or a cyanotic spell that I talked of. So most common complication is a cyanotic spell. What is happening basically? The most important thing which we know we should consider as developing for the development of a TET spell is an increase in systemic vascular resistance. That is the most important thing. Other things like crying, spasm of right ventricle outflow tract, these are questionable queries. But increase in SVR, if you're supposed to say one factor which will precipitate a TET spell, it is increased systemic vascular resistance. Whenever there is increased systemic vascular resistance, this will precipitate an increased right to left shunting, more cyanosis. What happens whenever there's an increased right to left shunt? What you're simply getting is a case of you're going to get a case of acidosis, which will generate. And whenever there is acidosis, whenever there'll be a high PCO2 which is there in this patient, the respiratory centers in the brain will be activated. And what do we do in response to an increased carbon dioxide levels in the blood? We try to wash out that CO2 by breathing faster. This is hyperpnea. What is tachypnea? It is increased rate of respiration. What is hyperpnea? It is increased rate and depth of respiration. So both the rate and the depth of respiration increases. This leads to a negative suction pressure in the thorax. We already know whenever we are inspiring, the venous return to the heart increases. Why? Inspiration predominantly causes a negative interthoracic pressure that causes a suction pressure, which leads to venous return increasing. Whenever this kid will have a hyperpnea, increased rate, increased depth of inspiration, the systemic venous return will concomitantly increase. So that will further, lead to an increase in the right to left shunt. So TET spell is anytime there is a clinical worsening of cyanosis, anytime the kid is crying, anytime there is hyperventilation, anytime there is hyperpnea, and as I said, disappearance of a previously heard ejection systolic murmur. I already told you, up till a certain point, murmur will increase. Once the maximum intensity of murmur is heard, any further obstruction will lead to disappearance of the murmur. What do you do? What was saving the child? Squat. Can you make a sick child squat? No. Just don't tell the child to squat. Make something which is equal to squatting, which is knee chest position. Move the knees close to the chest. You're exactly doing the same thing. You're increasing the systemic vascular resistance, thereby reducing the amount of shunt. So after this, you give O2, you avoid painful procedures. Why is this important? So when we are in residency, so this is something which my teacher taught me, that whenever a kid of TOF comes to you with a TET spell, every resident is almost hurrying up. I need to do a cannula right now. I need to do a cannula. I need to inject. No, avoid a painful procedure, because when you induce a painful procedure, the kid starts crying. And as you see, crying will increase the right to left shunt. So I just need to calm the child. First, do a knee chest, give oxygen, avoid painful procedures. Once This is being maintained. Now I need to calm the child down, sedate the child, give morphine, which is at the rate of 0.1 mg per kg subcutaneous. Once the kid is now calm and stable, now do an IV access. This is an extremely important point. So will you do an IV access before? No, you will actually inject morphine, make sure that the child is calm, not crying, and then only you will start with an IV access. What do I need to treat? Very simple. There was acidosis. I need to correct the acidosis. I will give soda bicarb. How do I give it? It is slow IV after diluting. What else do I need to do? What was the cause of the TET spell? It was a right ventricular outflow tract spasm. And what was happening? Due to this, I need to increase the systemic vascular resistance. I need to abolish the spasm, for which I will be giving injection propranolol. If this does not work, my next step is injection phenylephrine or methoxamine, which just like knee chest or squatting increases the SVR, or I give ketamine slow IV. If till now, after 3 attempts of so much, still the baby is not stable, I should now consider PPV, that is positive pressure ventilation, and an emergency palliative surgery. The sequence of these steps is extremely important. So first bicarb, soda bicarb, then propranolol. Things not working, go with phenylephrine or methoxamine. Consider ketamine with keeping in mind the possibility of a positive pressure ventilation. So emergency palliative surgery. When I talk of emergency palliative surgery, I predominantly talk of this modified BT shunt. There's nothing else which is done right now as emergency palliative. And the ones who are my juniors who are studying in undergrad, you might come across Watterson shunt and pot shunt. So this is a simple mnemonic which I created. I'd learned this many years back. So it's simply for the ones who know Hindi, it's bas wahan pahuncha do. So basically what we do is in this shunt, we are simply trying to create a bypass in between the aorta and the pulmonary artery. I will just have to create a bypass in between the pulmonary artery and the aorta so that the large amount of blood which is moving from the right side to the left side is shunted. So that is something which I need to make. And in a modified shunt, what do? I just connect the left subclavian artery to the pulmonary artery, right? So that is exactly what I do, so that whatever blood the aorta pumps out, I don't let it reach the systemic circulation because it's a mixed blood. I don't let that happen. I drive that blood back into the lungs through the pulmonary artery. So in all of these shunts, of be it Watterson shunt, be it modified BT shunt, be it pot shunt, in all of these shunts, the ultimate destination is the pulmonary artery. Now, what are we joining to the pulmonary artery? We simply remember it by this. Bas wahan pahuncha do. B is modified BT shunt, where S subclavian artery is joined to the pulmonary artery. Wahan W is Watterson shunt, and A for ascending aorta is shunted to the pulmonary artery. Pahuncha do, PD pot shunt is descending aorta, which is shunted to the pulmonary artery. It's a mnemonic which I read back in my undergrad days, so I just remembered it and wanted to put this up for you. In medical management, as I said, once this kid has been saved from this TET spell and is doing well, I discharge the kid home after an emergency surgery. I discharge with an infective endocarditis prophylaxis, oral propranolol, because it will it'll increase my systemic vascular resistance. Propranolol will increase SVR. It will also reduce my heart rate, and low dose iron orally. This is again something which I can expect AIMS to put up as a question sometime, because this is an atypical management. Why is low dose iron suggested to these kids? Number one, it maintains a negative iron balance, and it also reduces the chances of stroke in these kids. So oral low dose iron is often prophylactically recommended. The complications after this emergency BT shunt may be a chylothorax, it may be Horner syndrome, it may be a diaphragmatic palsy. I'm not going directly into that, but I want to talk of three situations which are asked as real life cases, and we encounter this very much. Number one is I did an emergency BT shunt. I did a modified BT shunt. Now, when a child comes to me, I find post emergency shunting, there is a continuous murmur over the lung fields. What do I mean? Should I be worried? No, I should not be. I did a BT shunt considering that this was a TET spell. In a TET spell, murmur was absent. Now I'm finding the murmur back again. I should be happy. It's a well-functioning shunt. Number two, gradual onset worsening of cyanosis in a patient already having a shunt in situ. This suggests shunt insufficiency. If it's a gradual onset, it's a shunt insufficiency, which means I need to reconsider that shunt, or I need to move to a definitive procedure. Number three, a sudden onset cyanosis. If there's a sudden onset cyanosis with a shunt in situ, it is usually a shunt block, which is an emergency, and the shunt block is usually due to thrombosis. Three case scenarios: I think they've never been asked at undergrad level, but if it comes someday, you can always remember this back from there. So after this emergency BT shunt, I really need to look back now at a definitive surgery. Whenever I've done a BT shunting, 1 to 2 years later, I will simply do a definitive surgery where I'll close the VSD. And if the if there was a subinfundibular stenosis, I don't touch that. I leave it as it is. If a pulmonary valvular stenosis was there, which can happen in 15 to 20% of the cases, I will just put a transannular patch and close that valvular stenosis. I mean, that patch is going to relieve the stenosis only if a valvular involvement was there. If it was a subinfundibular stenosis, which is maximum 40 to 50% of the cases of TOF, I will not touch it. I'll just do a VSD closure. However, if there's a patient who is having a TOF with a favorable anatomy, and this kid never required a BT shunt, say there was no TET spell, there was nothing of that sort, I will simply go with a VSD closure plus minus a transannular patch, most commonly done between 4 to 6 months of age. What do I mean by when I say if anatomy is favorable? I clearly mean if there is no MAPCA, number one, if there is no pulmonary atresia, number two. I will always go with this. The moment there is, pulmonary atresia or something, I will always have to first do an emergency BT shunt, then stabilize the patient, and then take up this patient for an emergency closure. I mean, for a definitive closure 1 to 2 years later. Anytime there is an asymptomatic TOF with coronary artery anomalies, that MAPCAS, I will repair by 1 year of age. I will just place a conduit between the RV and the PA. See, anything that I'm doing, be a modified BT shunt, be it a Watterson shunt, be it any shunt, I have to join something with the pulmonary artery. Why? I just need to shunt this entire amount of blood, which was otherwise supposed to go into the systemic circulation. I have to drive it to the pulmonary circulation so that the lungs are not oligemic anymore. So in coronary artery anomalies, I will simply place a conduit between the right ventricle and the pulmonary artery. And what are the indications of a definitive surgery? Anytime there's a cyanotic spell, I should always consider that once I treat the cyanotic spell with a BT shunt, I should always think of a definitive closure. Anytime there's a favorable anatomy, why wait? Why wait for a TET spell to happen? Straight away do it between 4 to 6 months of age. And as I said, anytime a TOF patient comes with a saturation of 75 to 80% as baseline presentation, I should always consider, even if this child is asymptomatic back then, I should always think that this kid is very, very likely to go into a case of cyanosis, TET spell, and let me not wait till then. I mean, why wait when you know what you can do? So that's all about TOF. The rest 2-3 diseases are just one slides. You can just brush them up so fast because it's nothing to discuss much in these cases at the level that I'm trying to target the audience as. It's tricuspid atresia. Very simple. You have an atretic tricuspid valve. You can clearly see that the blood will no more flow from the right atrium to the right ventricle. It has to move from the right atrium via an atrial septal defect, or mainly there's a patent foramen ovale actually, which leads to the blood moving from the RA to the LA, and from the LA, the blood moves to the LV. From the LV, it moves to the aorta. Now, where will the pulmonary circulation receive the blood from? That is where the ductus would come into circulation. So in utero, the ductus being patent shunts this blood from the aorta to the lungs. But once the kid is born, the ductus closes. No blood virtually reaches the lungs, which is why it is another duct-dependent circulation. What were the other duct-dependent circulations that we talked of? In a cyanotic, we talked of the coarctation of aorta. In cyanotic, we talked already of TOF. Here we are talking of tricuspid atresia, which is a very, very, very important condition where the duct needs to be kept open. Now, because of this, I need to give alloprostadil, which is a PGE1 infusion post-birth. And as you can clearly see, because the tricuspid valve is atretic, the blood is moving right from the right atrium straight to the left side. So the left-sided chambers will be enlarged. You will find cardiomegaly. You will find central cyanosis right at birth because there's complete mixing. And there'll be a left-sided chamber enlargement, which you will encounter on the X-ray. And do we have the X-ray? Yes. So you will, I don't have the X-ray with me right now, but I wish I could show you at some time later. You can clearly see this image. You have an atretic tricuspid valve. There's nothing which you find as a chamber of right ventricle. It's completely mainly the right atrium, which is shunting all the blood via a patent foramen ovale into the left side of the heart. So cyanosis in neonatal life, right after birth, when you get cyanosis, this is so common tricuspid atresia. It is a duct dependent circulation. The ECG will show you left axis deviations, chest X-rays will show you left chamber enlargements, and as I said, it is duct dependent. Once the duct closes after birth, virtually no blood can move to the pulmonary circulation. So give alprostadil followed by modified BT shunt. And what you need to do is, in some cases, if this patent foramen ovale is so small that enough blood cannot move from the right side to the left side, you simply create an opening in between the two atrium, which is called a Raschkein procedure. It is a Raschkein atrial septostomy. You basically burst the wall of the interatrial septum so that you allow this, because see, ASD is only keeping this child alive. There is no other way that this blood from the right side of the heart can come into the circulation. The only way that it can come is an ASD. If the patent foramen ovale is not really big in size, burst the interatrial septum via the Raschkein procedure, and you get a chance to to allow this blood which is flowing from the right side to the left side. After this emergency management, you plan a modified Glenn shunt between 2 to 6 months of age. And what you basically do by the Glenn shunt is, see, as the LV volume will start overloading, this kid will now start presenting with congestive cardiac failure. I don't want that. So what I want is, after I have made an opening, after I've kept the ductus open, I've saved the child's life. Now my work is to reduce the symptoms of CCF. So I'll go by a Glenn shunt. What is a Glenn shunt? This is not for undergrads. This is for people who are doing the residencies. So what I do in this Glenn shunt is, as you can clearly see, this is the superior vena cava. A part of the superior vena cava has been cut and it has been joined to the pulmonary artery, right? A part of it has been joined to the pulmonary artery. The other part of the superior vena cava, which is this part, a little part has been left with the right atrium, and I keep it like this. And what I do is I also cut the pulmonary trunk. We can clearly see, I will cut the pulmonary trunk here. Can you see the stitches here? The pulmonary trunk has been cut. A part of the superior vena cava has been cut and joined to the pulmonary artery. So cut and ligate the SVC, join to the right pulmonary artery, cut the pulmonary trunk, ligate it. So what happens is, now the superior vena cava, instead of draining into the right atrium, it will now directly drain into the pulmonary artery. Thereby, the lungs will no more become oligemic. After this, once I have done this, I have maintained the fact that no amount of blood is overloading the left ventricle, because every blood that it's coming via venous return is draining from the SVC to the pulmonary artery. I now need to do one final surgery, which is also called a lateral Fontan shunt. Again, what I'm doing is I'm inflating a bag through the right atrium. I'm joining the Glenn shunt originally, and now can you see, earlier the top part of SVC was ligated with the pulmonary artery, and there was the remaining part of SVC was not joining the pulmonary artery. But here in this case, we have joined this gap. So basically, the inflation of a bag inside the right atrium and joining of the remaining cut part of SVC to the previously created Glenn shunt is what we call a lateral Fontan shunt. Just basics of the surgeries, they'll never be asked at least the SS pediatrics level, because this is more of a pediatric surgery topic. I just wanted to explain you what happens, and we do this by the age of 2 to 3 years. So basically, three things: you first do an emergency management, save the cyanosis, then you start thinking of CCF, prevent CCF by directly connecting the SVC to the pulmonary artery, drain entire amount of blood from the SVC straight to the lungs, bypass the left ventricle, and later you just do a lateral Fontan shunt. That's it. Coming to Epstein's anomaly, one word at undergraduate level, Epstein is equal to lithium. Any mother who is taking lithium for bipolar disorder during her pregnancy, one congenital heart disease, just close your eyes, it is Epstein anomaly. What is Epstein anomaly? You can clearly see that there is an inferior displacement of the tricuspid valve, due to which the right atrium looks enlarged, the right ventricle looks small. In fact, this is called atrialization of the right ventricle. Due to this atrialization of the right ventricle, what happens is right ventricle does not function properly. Also, there's a regurgitant tricuspid valve, which leads to tricuspid regurgitation. And due to this, what happens is right ventricle is no more able to pump blood into the pulmonary circulation. What will happen? This kid needs to be alive via a patent foramen ovale. So right tricuspid valve already inferiorly displaced, right atrium is bigger, plus it is regurgitating. The blood will never reach the right ventricle into the pulmonary artery. It will just have to go via the right atrium through a patent foramen ovale and move to the left side of the heart. It is associated mainly with WPW syndromes, which is another clinical correlation which is asked. And it is a ductus dependent circulation, which means that there's severe cyanosis soon as the ductus closes. Another question which has been asked earlier is, it is associated with cardiomyopathy. The most common cardiomyopathy that is associated is a left ventricle non-compaction. You get a box-shaped heart. What is this? This is a box-shaped heart typically. The box-shaped heart is because of the enlarged right atrium, and the right ventricle is almost not present. And in ECG, you will get right bundle branch block in almost 80% cases. Because the right atrium is enlarged, you will get Himalayan P waves. You can see lead to, you can clearly see a large P wave. So The last disease that last two diseases, in fact, that I'll talk of, one slides for each. One is transposition of great arteries. As the name says, the great arteries, the great vessels have been transposed. Usually in you and me, normal people, the aorta rises from the left ventricle, the pulmonary artery rises from the right ventricle. You just switch this. The pulmonary artery is now arising from the left ventricle, aorta arising from the right ventricle. This is exactly what transposition of great artery is. It's called DTGA because in chemistry, if you remember, organic chemistry, back in our 11th, 12th days, dextrorotatory and levorotatory. So this is what we call a dextrorotated variety of a transposition of great arteries, wherein you are finding the RV is giving rise to the aorta, the LV is giving rise to the pulmonary artery. So what is happening is all the deoxygenated blood is going to the systemic circulation. All the oxygenated blood is going via the aorta to the lungs. So the only way that that something can be done about it. Okay, first, as I said, this is the system of parallel circuits that develops. So what happens is, I think it's a little blur, but I can read it out for you. What happens is, that the right atrium is receiving the venous return from the SBC and the IBC. It is draining the blood into the right ventricle. From right ventricle, you are having aorta, which is coming out, and this forms the systemic circulation. Aorta is sending the blood throughout into the systemic circulation. There is an ASD between the right atrium and the left atrium, which is allowing that communication, and there's also a concomitant VSD between the right ventricle and the left ventricle. This maintains this is what ensures that every chamber is receiving each other's blood basically, but outside the heart there is a system of parallel circuits. The pulmonary artery is, the pulmonary circulation via the pulmonary vein is draining the blood into the left atrium moving to the left ventricle, and the left ventricle is again, pumping it into the pulmonary artery instead of pumping it into the aorta. So that is exactly how there's a system of concomitant parallel circulation which occurs, and you can have this feature on X-ray, which is called a typical egg on string appearance or egg on side appearance, where every chamber you'll find each chamber is being dilated. The right atrium, the pulmonary connections, everything is dilated, as you can find. And one thing that I want to tell you is ductus is the only thing that would keep this kid alive, because the only way that the oxygenated blood from the right side can move to the left side is via the ductus. So the only thing that I need to do is, once the kid is born, I need to keep the ductus open. I will give alprostadil. The only other way by which the right-sided blood can come to the left side is via a Rashkind's balloon septostomy, where I will create that opening between the two atrium, and later, because it is just basically the two great vessels have been switched. So basically, I'll re-switch the procedure where I'll join back the aorta to the left ventricle, and the right ventricle will be joined to the pulmonary the right ventricle will be joined to the pulmonary artery. So that is what we call typically a Jayton's arterial switch, which is done by 2 weeks. And that explains majorly the TGA. As I said, most common cause of cyanosis in the first 2 weeks of life. And again, it is the most specific congenital heart disease, which is found in an infant of diabetic mother, associated also with syndromes like Digeorge syndrome, which is catch-22. Last but not the least is TAPVC. When I talk of TAPVC, it is total anomalous pulmonary venous circulation. Normally, the 4 pulmonary veins will drain into the left atrium, but in this case, they drain into the right atrium. So what happens is the oxygenated blood is directly draining into the right atrium. The left atrium is not receiving anything. The only way by which we can, instead of the right-sided chamber enlargements will start occurring, because everything from the lung is virtually coming into the right atrium. Complete mixing will occur in the right atrium. Right atrium is receiving deoxygenated blood from the SBCs and IBC, and oxygenated blood from the pulmonary veins. There will be a complete mixing occurring in the right atrium, and that will lead to an enlarged right atrium, which you can see here in this chest X-ray. And it is only the fact that just like TGA, both ASD and VSD is what makes life compatible, because these are the only 2 openings by which right-sided blood can somehow come to the left-sided. There are 3 types basically that we get. One is a supracardiac TAPVC, where the pulmonary veins drain into the right atrium, above the heart. There's an infracardiac, where the pulmonary veins join below the heart to drain into the right atrium. That means they join to the IVC, which further drains into the right atrium. And there's an intracardiac, where directly the pulmonary veins join to the right atrium. At a level which I am targeting, I'll only tell you that infracardiac is associated with a lot of obstruction and hence can present with obstructive shock and has the worst prognosis. The supracardiac variety is a good variety to have, and that is the one which shows me this classical snowman or a figure of eight appearance. And this common vein that these four pulmonary veins form is also called the innominate vein. This innominate vein is receiving the blood of all these four pulmonary veins and draining to the right side of the heart. The right, you can find this very clearly that the right atrium is enlarged. The right heart border is clearly enlarged, and because this entirely this blood is again going back to the lungs, you will also find an enlargement of the pulmonary arterial segments. In cases of supracardiac, you get this appearance, whereas in case of infracardiac as well as cardiac varieties of TAPVC, you simply get a white out lung. This is a simple white out lung, which can be found in a multiple other disorders of neonatal respiratory and cardiac disorders. So this is not really very specific, but this, whenever we talk of snowman, we are simply meaning the supracardiac varieties. Okay. One more thing, which is often asked at an undergrad level, is because every pulmonary vein is draining its oxygenated blood into the right atrium, there's also an associated ASD and a VSD. So basically the mixing which has happened in the right atrium, this mixed blood is circulated across all the chambers of the heart, which means there's an equal saturation of oxygen in all the chambers of the heart. And this is predominantly found in the supracardiac type. So what did I sum up with? Infracardiac is shock, obstructive symptoms, bad prognosis. Supracardiac comes with equal saturation in all chambers and is associated with the snowman appearance or the figure of eight appearance. Truncus arteriosus is what I'll end with. When I talk of truncus arteriosus, it's very simple. Usually in our body, we have two different vessels, great vessels originating, right? The left ventricle giving rise to the aorta, the right ventricle giving rise to the pulmonary trunk. But here in this case, there's one common trunk, which is then giving rise to the two vessels, which means that there also has to be an associated VSD, because otherwise, how will both the right ventricle and the left ventricle both pump its blood into the common trunk? There has to be a VSD. So this single arterial trunk is the one trunk which is giving rise to both pulmonary, systemic, and even coronary circulation. And it is overriding a VSD. It is receiving biventricular output. Both RV and LV is pumping its blood there. There is clear mixing and there is cyanosis. Truncus arteriosus associated with Dye-George syndrome, which is the strongest association, and can also be associated with interrupted aortic arch. At your level, I really want you to remember Dye-George syndrome, because there is really no concept of A2 and P2 separately, because I don't have a separate aorta and a separate pulmonary trunk. Hence, a single loud S2 is what I hear. Because there is a VSD, and this VSD is not usually a large VSD, that is why I will find a murmur of a VSD, that's a pansystolic murmur along the lower left sternal border. I will have to manage the cardiac failure symptoms, and I will have to do a surgery within the first 3 months of life. What is this surgery? It's called a modified Rastelis procedure. I simply close the VSD here. I put a conduit between the left ventricle and the aorta. You can see this. This is the closer of the VSD. Then I've placed a conduit between the left ventricle and the aorta. As you can see, this is the conduit. And finally, I will have to reconstruct a pulmonary artery. This is the reconstruction which a vortex graft, and the reconstruction of the pulmonary artery, and I have to join it to the right ventricle via conduit. Basically, it is just that I'm recreating the circuit. In TGA, what I was doing, I was switching the circuit, because that was the problem. The right-sided chambers was leading to the aorta. I was switching it via J-Ten's arterial switch. Here, in this case, I will simply reconstruct the circuit, because I will destroy the VSD, and I'll place a conduit between the LV and the aorta, so that the left side blood directly drains into the aorta. There's no problem. And I will create another conduit which reconstructs the pulmonary artery and joins it to the right ventricle. As I said, this is the typical X-ray that I get in case of truncus arteriosus. It's also called a sitting duck pattern, and this is what I will usually expect in a case of truncus arteriosus. After having said all of this, I always feel when you summarize things, it becomes better. It becomes better to revise, becomes better to look back. So anytime I talk of cyanotic congenital heart disease, I will have to see whether it is associated with oligemia or plethora. Is the pulmonary blood flow increased or decreased? Once I talk of oligemia, that means a reduced pulmonary blood flow, I will now have to see which chamber is enlarged. If it's the right-sided chambers which are enlarged, it is TOF. If it's the left-sided chambers which are enlarged, it is tricuspid atresia. Whereas if there's a right bundle branch block, if there's a WP syndrome association, lithium association, Himalayan P wave, it is Epstein's anomaly. And if there's cyanosis with plethora, that is lung fields are getting richly supplied with blood, I will have to see how is the pedicle. If the pedicle is small, and there is a complete switching between the two ends. On echo, I find a complete switch, the right ventricle giving rise to the aorta and the left one giving rise to the pulmonary trunk. It is a TGA. In case there is a wide fixed split, I told you earlier, wide fixed split for an cyanotic disease is something that you will be seeing with PDA. Wide fixed split for cyanotic disease is what you will find with cases of TAPVC. Equal chamber saturation is again what will come with supracardiac TAPVC. Snowman appearance again comes with supracardiac TAPVC. Infracardiac comes with shock. And a large pedicle with a sitting duck appearance, as I said, is truncus arteriosus. So anytime you want to have a quick look of these slides, just look at the last slide, add on whatever points you can recall into this slide, and that, in one page, it literally summarizes almost all the major findings that you get with all of these cyanotic congenital heart diseases. Actually, I tried to sum up everything in as little time as I could. It is actually a topic which the ones who are doing residency, they would know it better, and even for us as my juniors with undergrad level, it's almost a 50-60 page book that you would get on congenital heart diseases. Summing it up into 2 hours was difficult, but then thank you to all who have been here, and I'd be very open to answering questions if there's anything which comes from your end, and even wanting to know what you I could have done better, because that is something which I'll be always looking forward to, and trying to incorporate with in my further lectures. So thank you to everyone for listening to me. Thank you to everyone for being there, and means a lot. I would love to conduct these sessions more, trying to make it more integrated with questions, not really as more not really this Socratic method of conversation where I'm the one speaking. I really want it to be much more interactive. So let's look forward to more sessions like this, and I hope I can take up more topics like this further for you in the future. If I've been able to contribute in any good way to anyone at whichever level of preparation you are in, I'm really glad, grateful, and I'd love to know that. I'd love to hear from you. I want you all to carry from where we left today. I hope we can have such journeys again together. Thank you so much. Thank you.
Yes, thank you so much, Doctor. Before we conclude, we would like to open the floor for any questions you might have. Please feel free to type your questions in the chat box, and we will do our best to answer them. Additionally, I have already dropped the link in the chat box to follow us on social media for updates on future webinars and events. And also, kindly please subscribe our WhatsApp channel. Also, I have dropped a link in the chat box for you to fill out and submit to receive your certificates of participation. I repeat, I have dropped a link in the chat box for you to fill out and submit to receive your certificates of participation. So kindly please drop your questions in the chat box. We'll do the best to answer them. Yes, I can see.
Gagana, I'm not able to view the questions. Can you just?
Yeah. I will
Sure.
help you with that. I'm just searching for the questions. Thank you so much. Everybody have dropped that very nice session, truly informative and all. Thank you so much. So there is one question. I have one question. Why neonates on 0 day, 1 minute of life? Why SpO2 65%?
Okay. So okay. So you are asking me. Okay, can I know the name of this person who has texted? I just wanted to address.
I don't know his name. Like his name is Indian Institute of Learning Life Saving Skills. I think.
So first of all, good evening. Thank you for your question. I just wanted to let you know. So there may be multiple causes of a neonate presenting with low saturation at birth. The first thing that I'll talk of, birth asphyxia. When I talk of birth asphyxia, is one of the major causes. Any preterm neonate, any low birth weight neonate is most likely to develop with low cyanosis low SpO2 right at birth. This is the first and the most important thing. That is why we say when we talk of the national data for under 5 mortality, the predominant thing that comes up is always prematurity and low birth weight. This is the first reason. Second reason, it may be if it's a cesarean section and say there's nothing harmful, the first few minutes maybe there's something which is causing a transient tachypnea of newborn. That can be one thing which can lead to a low SpO2. There can be very serious cases like a hyaline membrane disease, which is also called a neonatal respiratory distress syndrome. This can be there, which can lead to this. You have multiple causes. When I talk of the cardiac end, I already talked of conditions which present with low saturation and cyanosis at birth. So if you're wanting to ask me from which angle, is it the respi angle or is it the cardiovascular angle, then there are multiple angles. But if you really ask me, if I have to just close my eyes and lift out 3 reasons, one is birth asphyxia due to prematurity and low birth weight. The second one being your hyaline membrane disease, and the third one being cardiovascular causes which lead to a drop in saturation right after birth. And which is why according to the according to the NICU protocol, it becomes very, very important to measure the saturation 0 minutes at 1 minute, and then at 5 minutes and 10 minutes. In fact, that is exactly what we calculate by the ABGAR score, where we are trying to indicate the prognosis of the kid as to how a kid is at 0 minute, 1 minute, 5 minutes, and 10 minutes of birth. So yeah, that predominantly answers your question. I'm not able to hear you, Gagana.
Thank you so much for answering the questions. I have some questions from my WhatsApp group from our students. I would like to answer. I would like to 1 second. Just give me a moment.
There's a question which I can find. Why neonates people start CPR when neonate is still having a pulse and heart rate is around 50? Okay, wow. Okay, so heart rate around at 50 neonate is an ominous sign. So basically, as I told you, hypoxia always comes with bradycardia, and anytime there is a heart rate which is less than 100, the NICU protocol always says that heart rate of 50 in case of neonates is really low. My friend, I'm not able to read your name, but so yeah, that is exactly why CPR is started. And let's be honest, CPR is not what we start. What we start is positive pressure ventilation. That is what we start first. Then we move to chest compressions. So there's a particular order in the NICU protocol. I'll tell you. If you're a final year student, I can presume you're a final year student or someone who is in your undergrads. Just go to Google quickly. Take a snapshot of the AIMS NICU protocol where it talks of neonatal resuscitation. The first golden minute of life, what we only do till first minute of life, we don't give CPR, we just give positive pressure ventilation. That the initiation of positive pressure ventilation up till that time, from birth of the child till the initiation of positive pressure ventilation, is the golden 1 minute. After that, if the baby is not responding to PPV, I mean positive pressure ventilation, then we think of chest compression. We try coordinating it with chest compression and bag mask ventilation, and then if still it's not responding at any point of time, if the heart rate is still below 60, so 50 you wrote, 50 is very low, my dear. So anything below 100 is very low, very low.
Thank you, doctor. Thank you for answering the question. There is one question. Are there genetic or environmental factors that increase the risk of CHD?
Yeah. So genetic factors, of course. I really talked of so many disorders where we were having chromosomal anomalies like trisomy 18, trisomy 13, trisomy 21. Downs is associated with a hell lot of anomalies. Endocardial cushion defect, you have ventricular septal defects, you have Tijot syndrome, which is associated with so many things. So this is exactly why, we cannot really screen for all the chromosomes, right? In a setup like India, it's virtually impossible to, screen every chromosome and find out what's there. But what we do usually as a part of antenatal screening is we do this anomaly scan in mothers who are at high risk. We do an anomaly scan, we do a target scan. So what I mean by the anomaly scan is I'm doing an echo. I'm trying to find out whether the kid is whether the fetus is having a congenital heart disease right in utero at 18 to 20 weeks of pregnancy. It is a recommended guideline that every pregnant female, irrespective of her age, irrespective of her time, of how many number of children she has to undergo 18 to 20-week anomaly scan. In fact, the government of India clearly says that if you are not having enough financial resources and there is one investigation that you would want to do, one USG that you would want to do, one radiological investigation that you would want to do, it is the anomaly scan, nothing more. If there's nothing available, so 18 to 20 weeks anomaly scan is very important. Number two, talking of the genetic disorders, as you said, yes, we can do an aneuploidy screening. Every mother above the age of 32 in India is always recommended that you have a screening for Downs, wherein we are trying to screen out not just Downs but many other trisomies. We have tried to introduce markers which will try to tell us whether a certain chromosomal anomaly is there. If that is found, we try to see what are the cardiac defects associated with that anomaly, and we try treating accordingly. If it's something which is treatable, it's good. Otherwise, we unfortunately have to go with an abortion, so as to save the life of the fetus and the mother. So that's how it is. We have genetic testing. We have a lot of prenatal testing coming up. In fact, there's a lot that is working out in the genetic, and trust me, 10 years from now, genetics is going to be a hot branch. It's just going to be a hot favorite branch, because we will have a lot of good resources, and I'm very sure about it.
Thank you, doctor. Thank you for answering the question. There is one more question, that is, how do structural abnormalities in CHD affect the hemodynamics of the heart?
How do structural anomalies in CHD affect the
Normalities.
yeah. So yeah, it again depends. So if it is something like a VSD, where there is a ventricular septal defect, which is shunting a lot of blood from the left side to the right side, it is increasing the blood flow to the lungs, and then that blood is coming back from the lungs to the left side of the heart. So that will lead to right-sided chamber enlargement. So whenever there's a right-sided chamber enlargement in utero, this kid, postnatal, whenever there's a large left-sided enlargement, this kid will present with frank symptoms of congestive cardiac failure. So again, even in cases of Eisenmenger syndrome, if you find whenever there is a reversal of shunt that is happening due to right ventricular hypertrophy that is caused due to a large amount of vascular remodeling of the pulmonary artery, whenever you have a right ventricular hypertrophy, again it is changing the hemodynamics of the heart, because normally your left ventricle is supposed to be thicker than the right ventricle, but in Eisenmenger the right ventricle is getting thicker, it's getting hypertrophied, and that is leading to the reversal of shunt. So any structural heart disease, if you know what is basically the pathophysiology, you will actually find which chambers are being enlarged. So basically, when you study this topic, you have three things to address. Number one, what is the pathophysiology? What is leading to this change from a normal to an abnormal thing? What is the thing which is causing the abnormality? Number two, what effect is it having on the chambers of the heart? Is it leading to any chamber enlargement? If yes, which sided chambers are enlarged? Number three, what are the clinical manifestations? If you can address these three questions, it's always done, because everything will come with its unique set of abnormalities that we'll get.
Yes. Thank you, doctor. Thank you so much. I don't see any questions, so I think we can now proceed further.
Yes.
Yes.
Thank you for all the questions that I got, and I'd be working harder. Next time maybe, as I said, I'll be trying to make it a little more interactive. So we can try doing that, because I personally believe in a more didactic way of communication. So let's just ensure that happens.
That's great. That's great. Thank you all for joining us today. We hope you found this webinar informative and valuable. If you have any further questions or would like more information, please feel free to reach out to us. I've already dropped a link in the chat box. Kindly fill out to get your kindly fill out to get your participation certificate. Don't forget to follow us on social media for updates on future webinars and events. Have a great evening. Thank you, doctor. Thank you all.
Thank you so much. Good night, everyone. Stay blessed.
We can leave, doctor. Kindly please exit from the meeting. The webinar is over. I would request everybody to exit the meeting. The webinar is over. Thank you all.
क्या? Hi, everyone.